thank you so much for having us. We're really excited to talk about a topic that we're all super passionate about. And we'll talk a little bit about our story and how we kind of got to this place, and how our interest and it's hard to say expertise, because I feel like there's still so much we're learning about this population as we're working with them. But I think we've developed kind of an interest and expertise in this population specifically. So to talk a little bit more about how we treat this population, how we think about access to services and barriers that this population might experience. So we have no potential conflicts of interest or in relation to this presentation. So here are just the objectives that we're hoping to cover throughout our presentation today. We want to be able to just share broadly about the stressors and barriers to care that Spanish-speaking and Latinx populations commonly face in navigating health systems. We also just want to be able to share some more information about the importance of striving to deliver more equitable, inclusive, and culturally responsive care for patients and families, specifically as it relates to Spanish-speaking and Latinx populations. I think that this is probably something that we're all striving for in each of our different medical specialties or specialties within the hospital. And so we'll talk more about how we try to do this in our work in mental health and psychiatry. And then the third one is to describe strategies to help recognize and address patient family care needs that bilingual and maybe more broadly diverse populations may experience, so that we know how to address them in our care and interactions with them. So we wanted to share a little bit about our story, like how we got started and what we're doing as far as treatment and care for this population. So Dr. Black and I actually met while we were doing I was doing my postdoc, they were doing their fellowship. And so we kind of bonded on our interest in working with bilingual Spanish-speaking and English families in psychiatry. And we were both staying on after finishing our training. And as we were talking about our interest in this population and wanting to serve this community more, is how this kind of idea of developing a clinic specifically designed for providing mental health assessment and treatment for this population kind of flourished. The development process, I mean, we're happy to talk more about how that was if people are interested. But essentially it included doing a needs assessment with the community, and then thinking about how can we complement services that are being offered in the community for Latino population, Spanish-speaking patients and families, and then thinking about how we can fit needs that are not currently being met. And so that's kind of how the Comla Clinic got started. Right now, this is kind of our core team, and I would say there's definitely a few more folks that I couldn't fit on this slide. But we have myself as a psychologist, we have 2 attending psychiatrists, and then we just had a wonderful mental health therapist who's joined our team, Marta Buell, who's also providing care. And then of course we have trainees, including psychology postdoctoral fellows and psychiatry fellows who work in our clinic as well. All of us are bilingual, so we're able to provide kind of that language concordant care. And then the treatments that we're offering are mostly centered around like anxiety, depression, and doing some parent training. And the way we think about kind of those delivering those kind of evidence-based programs is that we take into account kind of those the family's backgrounds, language, their goals, their values, beliefs, and kind of thinking about how we're adapting those treatments as we're working with this population. Yeah, so I'll kind of stop there so we can kind of get into the content, but that's just a little bit about how we've launched into some of this work.
So we wanted to review like what are some of the stressors and barriers to mental health care for Spanish-speaking families and Latinx children and families, both kind of broadly as far as what the research shows, and then specifically kind of within Washington State, as well as within our own Seattle children's populations. What are the things that we most commonly see? So next slide, we have just overall some of the Latinx demographics in Washington State. So this map just kind of shows by color where you see the highest concentration of residents that are listed as Hispanic on like population data within Washington State. So as you can see, there's a little bit of a concentration in Western Washington, but even more so kind of in that Eastern Central Washington location. So as far as counties go, where we see the highest percentage of residents listed as Hispanic are in Adams County, where you see 67%, Franklin 55%, and Yakima 50%. So all around kind of these Central Eastern Washington areas. Within Western Washington, which, as we're based on Seattle Children's main campus, as well as South Clinic, those are kind of the areas that are geographically the closest to Oklahoma Clinic. King County and Pierce County and Snohomish County have the highest population of Hispanic residents. So this is something that we kind of kept in mind, like informing our clinic as far as who we wanted to be accessible to. As it happened, we were kind of forming around the time of the pandemic. And so as far as having accessibility with virtual care has made our services like more accessible to people that may be coming from far away, but also having some in-person services is helpful, especially given locations in Western Washington counties that have a higher proportion of Hispanic residents. In particular, at Seattle Children's, as far as the languages of care that families most commonly are requiring at Children's when it comes to languages other than English, according to 2020 data, Spanish is the #1 language behind English that families request their care in. The other languages most commonly requested are listed here: Somali, Vietnamese, Mandarin and Cantonese, which were combined here, Russian, Arabic, Amharic, and Ukrainian. And where this had particular relevance in the psychiatry division is that because of the step care model within psychiatry, typically the services and therapies that are offered are the first step of therapy that's offered at Seattle Children's in campus is group therapy. However, group therapies were not currently, at the time that CALMA was started, were not currently being provided in languages other than English. And so this was a major gap of care that we had seen that particularly the Spanish-speaking population is the language that's, behind English, the second most requested. But those families were not able to receive care within the group treatments at Seattle Children's.
So I just wanted to share a little bit about the mental health landscape of the Latinx children and youth that we work with. And so these are just some statistics. Some of them are old, and I'll talk a little bit more about how COVID-19 has impacted the mental health of Hispanic children and families. So in 2019, this graph here is from the Hispanic Research Center. And they published some research where they looked at, the rates of depression in adolescent females who were reporting these symptoms at the time. It was 2019, so this was pre-COVID. And they found that about half of the Hispanic adolescent females were reporting symptoms of depression or feelings of sadness and hopelessness. And then about 23% of those who were endorsing those symptoms had seriously considered suicide. This table just highlights depression and anxiety rates among Latino immigrant youth specifically. So this is a slightly different population. So this might be children and youth who are recently immigrated to the United States between the ages of 12 and 19. And so they surveyed both anxiety and depression symptoms. You can see at the bottom here that for the CDI, which is a depression screener, a cutoff score of 20 and above is considered like symptomatic. And then for the MASC, which is an anxiety screener, the cutoff score is greater than 56, then they're symptomatic for anxiety. So overall, you can see that depression rates, the total is about 7% of the sample that they surveyed had symptoms of depression, and about 50% had symptoms of anxiety. Here you can see this is looking at ADHD rates here, and so for the Hispanic, it's probably very small on your end, but for Hispanic populations, it's kind of this brown line over here on this graph. So you can see that the rates of ADHD, when you compare to other racial ethnic categories, is probably not at the same rate. And there we'll talk a little bit more about as far as barriers that might get in the way for seeking out services, seeking out an evaluation, accessing treatment, all those kinds of things. But based on the study from 2021, when they looked at Hispanic children and youth who had a diagnosis of ADHD, the rate at which they had a diagnosis or received a diagnosis was less than compared to specifically white or Black or African American children and youth. So since the COVID happened, there's been a lot of studies that have been published about the impact of COVID and how that's affected health or mental health disparities in communities that were already pretty vulnerable. The thing that I would say is that there's not a whole lot of research that has been published specifically on Latino Hispanic populations, and that's kind of surprising to me. I'd be curious to see if there's more that's yet to be seen or published. And it's surprising because from what we see about the impact that COVID had on specific populations, we know that Latinx or Hispanic communities were one of the hardest hit because of the economic and social stressors that were tied to the pandemic. The studies that have been published have looked specifically at Latino or Hispanic girls. And so one of the things that this study found from 2022 was that Latinx girls experienced an increased rate of internalizing symptoms and worse school performance. And they tied that specifically because what they found is that Latinx girls or Hispanic girls in the study were given like increased childcare responsibilities, which was one of the stressors that they may have experienced, from maybe their families were still having to go to work. For example, maybe they were considered the essential workforce and having to kind of stay home, take care of younger siblings. So all of that was kind of tied to some of the concerns with increasing internalizing symptoms. The other thing that they looked at was that they looked kind of at the trajectory of internalizing and externalizing symptoms during the pandemic for youth that had symptoms of mental health pre-pandemic. And what they found is that there were actually reduced internalizing and externalizing symptoms during the pandemic, which I think can be a little bit surprising. What they found in this article, though, was that for youth that had pre-pandemic mental health symptoms who were now kind of removed from environments that were potentially stressful. So for example, like school, if they weren't having to attend school, stressors or social dynamics that may have been stressful, being removed from that environment and being at home, maybe reduce some of those stressors that were potentially causing, other mental health issues to kind of escalate. The other things that they cited was that there could be a lot of family protective factors that were associated with Latino youth being or staying at home during that pandemic. So when you look at the literature on like cultural values for this population, for example, there's a lot of there's a value called familismo, which is the more time or the cohesion that you experience within your family can actually be protective. And so in this study that described that during the pandemic, when people were having to stay home, that was probably a protective factor for these youth. And so they may have had increased family time. They were able to probably build relationships within their family. There was that reduction in those peer stressors. Maybe the academic pressures were a lot lower. And so not having to go to school and being at home, kind of the flexibility and routines that allowed for may have again contributed to those reduced internalizing and externalizing symptoms. Again, I wouldn't rely so heavily on these results because it's only 2 published studies, so I think that we'd probably have to see more in the coming years about how the trajectory of mental health symptoms has moved as we move out of the pandemic. And now that we have kind of a framework for where mental health symptoms are for this population, I think it's important to talk about like access and engagement. And Dr. Santillan is also going to talk a little bit more about the barriers and why access to treatment might be challenging. But when we look at the literature on access and engagement to mental health treatment, what we see is that for youth that have, Latino youth specifically, that have 1 or more mental health diagnoses and about moderate impairment, that these youth are 2 times less likely to receive specialty outpatient mental health services when we compare when we compare to youth from white backgrounds, for example. You can see the percentage here is 55% of Latino youth versus 73.2% of white youth who access outpatient mental health services. And then once Latino youth are actually part of the mental health system, the mean number of visits that they attend is significantly lower than that of white youth. So on average, Latino youth might attend 12 visits compared to 24 visits. So we do see that the access and kind of once they've accessed the treatment, the engagement piece is hard to sustain.
And when we're thinking about accessibility to treatment or just treatment in general, we often use this ecological systems theory. And the reason for this is that this theory provides information about multiple levels that contribute to disparities, such as access to treatment or participation in treatment. And so the ecological system models, it includes multiple different levels and systems that are related to an individual, regarding the relationship between like community and societal factors. And it's really important to understand how these factors contribute to the disparity in access to treatment, and also to how a patient is responding to treatment or their participation in treatment. And so often I'll use like a quick example of someone that we've seen recently. And we think about the individual level factor. And so what is it that, what factors are, what's bringing them to our clinic? But when we're thinking about that and we're thinking about the treatment and the treatment that they're receiving, we often have to think about other systems that are interacting with what is happening. And so, for example, within the microsystem level, we think about the home, the neighborhood, the school. So what's their school attendance like? What services do they have in their home? Their immediate family, are they Spanish speakers? Are they English speakers? Do they have understanding of the school system, the community services? And then we think more so again through a mesosystem. So then we're looking at a different level of, again, we're thinking about the neighborhood, the school, the work, like how are these factors and these family factors in their community contributing to the access that they have to mental health treatment? And also how might the lack of be barriers that are making it challenging for them to access treatment or respond to the treatment that we're providing. And then we also like to look through them through like an exosystem. So this is again more so we're looking at broader aspects of an individual's life that have an impact on them. And so we're thinking more so from like even more like policy factors that contribute to this. So a lot of times we're looking at immigration status or family immigration status, where if they've recently moved, if they how familiar they are with again community services, that their school services, and then just like overall broad policy that affects that individual level. It's still interacting with the individual, it's just at a broader level. And then that also then leads to this macro system where we're looking more at like cultural values, things that are associated with like stigma regarding mental health, acculturation to the US. And so we often see but patients who are in different levels of acculturation, some who have recently immigrated, others who have immigrated, who were born in the US and have parents that might have been born somewhere else. And then that level of understanding of all these other systems are really important for us to consider when we're thinking of how to approach treatment, and then also when we're thinking from a broader level of how to increase access to treatment. And then we also like to look at this through two different lenses. One, it's like the structural barriers that are systemic barriers that are in place that make it really challenging for families to access our services. And then other like attitudinal barriers or like cultural barriers that may be impacting participation and access to services. And so some literature has reported on the cultural mistrust that there is in the mental health system from different communities. And again, this might be regarding from previous experiences that they have had stigma in their communities. There's also literature that documents the desire to handle the problem on their own. So like this is something that I'm noticing that is happening in on my child, but I think that we know how to navigate that. And then perceived discrimination by healthcare providers. And so again, kind of relating back to that mistrust in the mental health system and the providers for mental health treatment. And then again, when we think of the structural barriers, looking through that ecological systems model, sometimes there are things that are like lack of insurance, economic status, English proficiency, lack of like connection with like a match between the patient and provider regarding ethnic or racial background, and then other systemic challenges like transportation, work scheduling appointments, making it to appointments, finding childcare to make it to those appointments, taking time off work. We only like offer appointments at certain times of the day, and then low literacy, because for a lot of this, for attending and accessing the services, there's a process in initiating those resources, and so those are all contributing factors that can impact the access to our treatment. And there's some research that has also found that these, specifically the cultural and like attitude towards mental health services has also been found in other countries. So this tells us that this is not something that's just occurring in the U.S., that it's something that also occurs in other Spanish-speaking countries. So this study specifically focused in families in Spain, and similarly, there reports of parents wanting to handle the problem by themselves. So like whatever is happening in our home is something that we take care of within our home system, and we don't have to have other people involved in it. And then thinking too that the treatment won't work. And so again, that mistrust in that mental health system, and not thinking that whatever the treatment that would be recommended would not be helpful. And so this, again, also has been reported in other Spanish-speaking countries across the world, not just the US. And then this is a list of barriers that have been reported in accessing mental health services. And this, again, it highlights a lot of the different factors that we've discussed in previous slides. But what we really like about this slide is it shows which barriers were reported with more frequency. And so the top 3 that were reported were that families do not know how to access services, that they wanted to handle the problems on their own, and then feeling like the child's behavior is normal. And so not knowing, having that challenge of not knowing when a behavior is, when a challenging behavior is something that is more so than what we would typically expect. And so those among this list, these were the 3 that came up more frequently for why families don't, what barriers they experienced while they were in their journey to finding services and supports.
Mm-hmm. Yeah, and the cool thing about this table too is that it specifically touches on youth whose parents completed a CBCL form. So a CBCL form is the child behavior checklist that looks across externalizing and internalizing symptoms. And so for those that had clinically significant internalizing or externalizing problems, the barriers that Dr. Sempian pointed out are those that for that population they found to be the barriers that they experienced in seeking or accessing care.
So let's get into a little bit about what we know about delivery of equitable, inclusive, and culturally responsive care, what the research shows, and what our experience has been. So a few key points about this. So one of the first things that we really emphasize in CALMA is language concordant care, meaning that the language that the care is being delivered in is the language that the family is most comfortable receiving that care in. And so our clinic in particular is a limited resource that is only providing care for families who do have that preference or need to receive their care in Spanish. Oh, and I think I see a hand. Do we have a question?
That was an accident, sorry.
Oh, no worries. So again, we're limited resources for Spanish-speaking families because the care is being provided by bilingual providers in Spanish. Another principle is culturally adapted care. So it's not just enough to kind of run all of our materials through, a translation service or what have you. Like we do really have to, it is important to really think about like what is, how care can be culturally adapted and how it can be made most responsive and relevant to the patient population we're treating. And in addition to that, adaptations that address issues like acculturation, immigration stress, which can be both like cultural, structural factors that can affect both mental health symptoms and how care is being provided, as well as how patients are responding to care. And so we have a little visual here that talks about the process of how that cultural adaptation takes place. So this is kind of written out as a three-step process, but really is something that kind of continues to get repeated and revisited throughout the delivery of any sort of culturally adapted care. So step one is where you set the stage, you review the concepts of the material, the treatment that you're delivering, and the strategies that you're going to be using, and reflect on how the cultural fit is for the population you're hoping to adapt the treatment for. Also assessing the community need and evaluate possible adaptations that you can make to the need that you're trying to fit. The next phase, you make an initial adaptation based on those factors. So you tailor your intervention from the get-go to the different cultural factors and circumstances and community needs that you've identified. And you evaluate any measures that you're going to use for cultural appropriateness, as well as looking at what measures you might be able to use to see how your process is working. Then the third step is adaptation iteration. So you continue this iterative process for adaptation, continue field testing, asking families for feedback on how things are going, look at any measures for how the treatment is working, and return to the previous stages to do further adaptations as you go. As we mentioned, language concordant care just intuitively makes a lot of sense. I think most people, if you were to just ask them on the face of it, do they think it would be better to receive care, in the language that they prefer to receive care in or not? Like, intuitively, we're all going to say yes. But this is a service that can be pretty hard to come by. So it's also helpful to look at the research to support like that language concordant care does actually make a big clinical difference. So, for example, language discordant psychiatric evaluations, actually, there's strong evidence that they show less diagnostic reliability than evaluations that are done with bilingual clinicians or interpreters. The clinicians also, we've seen that clinicians do their evaluations differently when there's not language concordance, and this can be the case both with or without an interpreter. So clinicians who are doing language discordant evaluations were seen to ask more closed-ended questions. They assessed patients as more guarded or uncooperative than when there was language concordance. With patients who were conversant in both Spanish and English, so patients who may have been capable of participating in the evaluation in either language, the psychiatrist rated greater psychopathology such as thought disorder, so for example with psychosis, or intellectual disability when observed in Spanish versus when they were observed in English. So even when families, for example, oftentimes under duress, families will they'll use kind of whatever level of English is available to them to participate in evaluations if they don't have an interpreter or a language concordant provider available. And what this evidence shows us is that those evaluations are not going to be of the same accuracy, of the same quality, and that clinicians are going to both approach them differently and evaluate them less accurately. Patients also, when evaluated in a language discordant encounter, they gave shorter answers, less self-reportive symptoms, particularly trauma history, as well as more speech disturbances, which again influences what evaluation and diagnosis they may receive. And interpreters were noted to make errors more often in patients' words than in psychiatrists' words, and this was particularly marked in psychosis. So even when you do have access to an interpreter, having that language discordance is going to more often lead to a less accurate portrayal of what the patient said versus what the clinician said. As we can imagine, this definitely has a significant impact on patient outcomes. On the positive end of things, when Latino patients do have a bilingual, bicultural clinician, there's evidence they have a better working alliance, and patient communication is more patient-centered. Ethnically matched dyads also can improve duration of treatment and outcome of treatment. Patients who were matched with a bilingual clinician generally had a longer duration and greater frequency of contact with community care teams, which is significant, especially given what we mentioned before about Latino children having fewer encounters when they actually do access treatment, and a shorter duration and lower frequency of contact with crisis teams. So more receiving of the everyday treatment can prevent the need for crisis team intervention. When we're looking at the evidence for culturally adapted care, so a large review meta-analysis in 2018 looked at all the reviews of culturally adapted care, psychiatric care since the year 2000. There was only 12 articles that they had available. Most of these, though, reported a moderate to large effect size. There was one article that directly compared adapted versus non-adapted interventions. And this showed that culturally adapted treatment outperformed unadapted treatment. And this in particular was moderated by cultural adaptation of the illness myth. So we may know this as the explanatory model. And so basically this means that the way that someone within their cultural perspective would understand their illness, the way they would explain it, say to someone they know or to someone in their family. It's really important that that aspect of treatment be culturally adapted because we're trying to place things in context of what makes sense to our patients and not how we would explain things from our background. And I guess specifically what I mean there is I think it's important as clinicians to be aware that our clinical perspective is also a cultural model. So when we're talking about an illness myth or an explanatory model, that comes also from kind of the culture of psychiatry, the culture of medicine, the culture of mental health treatment. And so it's important for us to remember that we're whether we're providing care in a medical setting or in a psychiatric setting, that we're trying to explain things in a way that connects from a more patient-centered perspective rather than from a medical or mental health provider perspective. As far as limitations on these studies, so again, the study designs are not necessarily super consistent. We're not necessarily comparing apples to apples when it comes to these studies. There's not a ton of studies as well. Usually the specifics of the cultural adaptation are not necessarily included in the study information, so it can be a little hard to track exactly what it is that makes a difference. A little bit of the specifics of culturally adapted mental health interventions and what was observed, and we pulled out these three categories because these are the categories that we have treatment groups within the Calma Clinic addressing. So, if, for example, parent management training, which is often a treatment for ADHD, in that instance, cultural adaptation of treatment was connected to improved retention and attendance, as well as satisfaction, feasibility, and effectiveness. So definitely improved outcome from the patient-family perspective. Depression, individual and group CBT benefits were greater and longer lasting than IPT in Latino youth up to a year after ending treatment. So there was some sustained benefit that was observed there. With anxiety, there's limited research, and this was surprising to us, given, as we had mentioned before, that Latino youth can be at greater risk of anxiety disorders, and there can be some differences in presentation as well, such as increased somatic symptoms or cultural idioms of distress, such as nervios. So given those facts, we were surprised that there's less research on this, but the available RCTs that we have support comparable CBT outcomes in Latino youth as compared to white youth with variable amount of cultural adaptation. The parental level of acculturation may moderate CBT outcomes, so that's an important factor to consider when we're culturally adapting treatment.
Yeah, and as Dr. Santian had mentioned earlier, looking at that ecological systems theory framework, a lot of times the adaptation process has to take into account the different layers of systems that patients and families live under. So when we're thinking about culturally adapting interventions, sometimes we do have to take into account, the families, if they may be experiencing immigration stress, if they've experienced discrimination with the system that they've interacted with, how motivated or how interested are they going to be to kind of re-engage with that system again, thinking about the structural issues and just access and how, as we saw in that framework, there was a lot of different things that might be contributing to access, including those cultural beliefs or attitudes about treatment, that and the other structural issues that might come up, like language, like transportation, and all of that. So sometimes adapting treatments might also have to, we might also have to think about these other variables. So we wanted to share this pyramid that I think highlights really well how we can take into account adaptations, what components of a program or intervention or system within where you're trying to do adaptations. And this one is actually been adapted from another, I think it's called an ecological systems model that was developed by Bernal and colleagues. And so it's been adapted by Schilling. So this is who's kind of published this pyramid here. And you can see that within the pyramid, there's at the bottom, we have setting and staff, which are changes that you can make to a program intervention to adapt it. And these are probably visible changes that the family on the patient-facing side of things, for example, they might be able to see these actual adaptations that have been made. And the further you go up on the pyramid, these are things that where you're getting more at the changing kind of the cultural framework of interventions or programs. So that ends up being more of a strength-based approach. So when Schilling kind of published this work, they also did a review of culturally adapted parent training programs specifically. As we mentioned, that's kind of the one of the gold standard treatments for parents who have kiddos with ADHD. And so they looked at those groups, and they found that the most of the programs that had been adapted focused specifically on adapting language and then staffing specifically. So staffing meaning that they're finding folks who are performing the intervention who reflect the characteristics of the target population. So whether it's Spanish-speaking families, having providers who are bicultural, bilingual, or bilingual who can deliver the intervention. And then the language communication piece would be like translating a manual from one language to another, including maybe, if there's metaphors or cultural sayings that might resonate with the family, if you're trying to explain a specific concept, for example, that you're using things that are going to really reflect the community or things that they understand, or might help them understand the concept, and putting that into the intervention materials. And then in a meta-analysis of 99 articles, it showed that adapting language and goals were actually provided the best predictive outcomes. So doing this language here, and then the goals at the top of the pyramid here, you can see that specifically gets at framing interventions with the goals of the family. So taking into account the cultural background, maybe the values and beliefs that family has, and using that to inform like what is the family interested in terms of what are they trying to get out of the treatment, and framing the intervention to really match the goals of the family. The other ones that I haven't mentioned here would be like the setting. So really selecting a site for the intervention that you're thinking of delivering that takes into account where the population is going to be, and maybe where their preference is. The other ones here would be like the learning methods. So really modifying what is the way that you're delivering an intervention or a program that, again, is taking into account the population that you're hoping will have access to that information. So maybe that means you're providing materials in video form or in visual form if you're worried about families' literacy levels. And then the other two parts here at the top would be culture and experience. So incorporating specific elements of the family's culture into the intervention. So thinking about either the history or the unique circumstances of the family or unique traits that you can tie into the intervention to, again, to make it more, to resonate more, make it more significant and meaningful to the family. And then the concepts and frameworks would be thinking about different theoretical kind of foundations or issues that you feel like might need to be addressed in an intervention to be culturally relevant to the patient or family. So this, I think, all sounds very like theoretical. And so in a little bit, we'll share the pyramid and how it reflects the work that we do in our comma clinic to kind of target each of these things. I definitely don't think that we're perfect in any way, because when we mention how we kind of try to tackle this in our clinic, you'll see that there are still many barriers that we experience with families on a daily basis. And so I think it's kind of, like Dr. Black mentioned, it's a work in process. We're kind of going back to the adaptation stages, right? So we're thinking about the setting, we're thinking about what adaptations we need to make, we're field testing, and then we're kind of going back and figuring out, okay, we need to tweak things. And I think we are still doing that. So we just wanted to share a little bit about the strategies that can be used to identify and address Spanish-speaking families' care needs, because I think that that's probably the first step, right? And I think many of us probably have an idea from working with families that there are specific barriers, or maybe the family is not getting to an appointment, or they're not following through on a recommendation that we gave them to follow up with their PCP, or whatever the case may be. Those things are not happening. And so I think oftentimes we know that there is a barrier, but it's often difficult to know what it is exactly. And so we wanted to share a little bit about what tools and strategies might be helpful in at that, because I think once we know and can identify the barrier, then I think we can think about what supports or interventions are we needing to provide to make sure that the family gets to the next step in their care. I think, well, maybe I'll change the slide here. I think the first thing that can be helpful is kind of doing more broadly, like a barriers and needs assessment, because what we have found in our experience is that parents are not actually going to share what barrier or challenge they're experiencing. I think that for any family can be really hard to do. I mean, it puts us in a vulnerable place, vulnerable spot to be disclosing, what are we having a hard time with? And so unless we ask specifically, it's not something that the family is going to be really open or willing to share. I think as a hospital system, we're kind of getting better at this, because there's now SDOH screeners that many families in different specialty clinics are filling out. And so we have a better sense of what's the background that these families are coming in with, what stressors might they be experiencing as far as transportation, housing, food. And I think that's a good first step. The other thing is that we also need to be asking, if we're providing a recommendation to, for example, to talk to a PCP, that maybe the first question is going to be, does your child have a PCP? Who is the established PCP? If they don't have one, then our next question is, do you know how to find, a PCP? Because I think just giving a blanket kind of recommendation to follow up with someone, I think we're assuming that we think the family knows how to do that, or the steps that are required to do that. And I think oftentimes even those steps are a barrier in and of themselves. In our comment clinic, for example, we list over here on the right-hand side several of the barriers that we've encountered with families, mostly around work schedules. So the time at which we offer evaluations, or we offer our group therapy, for example, we've tried to be flexible with our model that I think is a little different than other psychiatry clinics or groups, for example. And it's not perfect. I think we still have families who tell us that time does not work, and so who are waiting for maybe a different group or therapy group time that's not what we currently offer. But so again, it's not ideal. I think it's always hard to know what's going to be perfect for everyone, but I think we're thinking creatively, or we're trying to think creatively about what could work for most families. The other is childcare. That is one of the primary reasons why we have still continued to offer our services over telehealth, primarily because a lot of times the patient that we're seeing specifically within the family, there might be other siblings involved, and so or coming to our appointment or that kind of thing might really require the parent to seek care for the other children. So telehealth really allows us for parents to have that flexibility where they could still join our groups or participate in an evaluation without necessarily needing to have somebody else kind of be in the home watching the kiddos. Travel and gas, again, that's another reason why we still continue to do telehealth resources. However, we still have families who still struggle either joining MyChart or figuring out how to set up MyChart or using the internet to connect, or the internet connection is really poor depending on where the family lives. We saw that Washington state map where a lot of Spanish-speaking families might be residing. And so within our clinic, because of our telehealth approach, we do often have appointments with families who are in Eastern Washington, Western Washington, and the connection sometimes can be variable depending on where the family lives. Zoom also is a platform that most of the families I would say that we've seen in our clinic now are familiar with, but then some families are still not very familiar with it. So needing to walk them through that process has required a lot of extra work. So I guess that's all to say that I think doing a needs assessment can be helpful in identifying what the barriers are. And then I think figuring out which we can tackle. I think tackling all of them at once can be challenging, but prioritizing a few that you most impact and then going from there can be helpful. So this is the triangle that I shared, or that was shared in an earlier slide. And we just wanted to kind of map on a little bit of what we do in the Comla Clinic that kind of aligns with some of the research on best practices for cultural adaptation approaches. So as far as our staff goes, all of our staff is bilingual. The majority of us are bicultural, and the majority of us are native Spanish speakers. So we try to tackle that end of things. The setting, again, is mostly virtual, and a lot of our groups are in the evening. So we think it's usually between 5 and 7 p.m. And the way that we're delivering the interventions is both not only in written form and live form when we're talking and delivering content to families and engaging in conversations, but then what we've also done is recorded a summary of what we're talking about and sending that out to families so that they can again review that information and if they need more repetition, that's available. The learning methods, kind of highlighting that what I just mentioned, that there's both workbooks and also videos that families are receiving. As far as language goes, all of our folks are certified bilingual clinicians. The materials that we have available have been translated, although we have encountered some errors and families give us good feedback about what makes sense and what doesn't make sense. And then because we have folks who are bilingual and also have learned Spanish from various different Spanish-speaking countries, we're able to kind of pull in words and vocabulary that might fit better with some families than others. And so that ends up being really quite helpful when we're thinking about idioms or metaphors that might be best used in that language in Spanish. And then the cultural experiences. So we're often talking to families as part of our treatment about how mental health was talked about in their family, or thinking about parenting. If we're talking about parenting strategies, having parents really reflect on those personal and cultural experiences that may have had, because I think that really influences how they're thinking about or engaging with the material that we're presenting. And then when we're thinking about concepts and frameworks, kind of going back to that illness myth, right? So how do they talk about anxiety, depression, and really tying in the way they think about it and the way they talk about it with how we're thinking and talking about interventions and strategies that we want them to use. And then the last one up here is, of course, we try to get a good sense pretty early on in our evaluations, a good understanding of the family's backgrounds, their values, their beliefs, what are their goals for treatment. And those things are really influencing how we're approaching treatment when we get to work with them in our group therapy approaches. The last couple of things I'm going to share here are just kind of highlighting some of the research that we're doing around to really increase access to evidence-based anxiety treatment. So this is a project that I won't go into great detail about, but it's one that I'm working on with Dr. Santillan, who's here, and Dr. Brent Collette, who's my mentor on the project. But this project was funded by the Center for Diversity and Health Equity, where we're looking at using task shifting models, so training other parents who participated in an evidence-based anxiety treatment to then help or coach or deliver an intervention to other parents who are now participating in a group. What this can allows us to do is actually expand our group size so that there is more, maybe more families who have contact with, psychologists or mental health therapists, but then are receiving individual coaching from. Essentially, you can think about them as peer coaches. In Spanish, we refer to them as promotoras. In the health literature, often promotoras are used to provide health education in primary care settings around diabetes, exercise, health, those kinds of things. But that idea and model has not been well studied in the mental health space. And so that's one of the projects that we are currently evaluating and trialing out. And then the last thing that I'll leave you all with is just kind of this quote that I heard when I was training at the time from a clinical psychologist, Ross Green, who would say, if your child could do well, he would do well. And if your child had the skills to exhibit adaptive behaviors, he wouldn't be exhibiting challenging behaviors. So that this was helpful in helping other parents think about their child's behavior. So that they felt more like, okay, I got to teach my child, how to do this because he's lacking the skills. And I like to take that approach similarly in the work that I engage with, or that we engage with families, because I think oftentimes it can be frustrating on the clinician or provider side of things when we oftentimes don't see follow through from families, right? And so I think I take this same approach when I think about the group of families that we see, that if our families could attend our clinic or follow through on our recommendations, I'm pretty sure they would. Right. And so I think it requires a little bit of a reframing of how we're thinking about their experiences and how can we change the system, or, how can we reduce barriers that they might be experiencing so they can attend our clinic and follow through on our recommendations. And I think that is it.
Thank you so much for your presentation. And folks, if you have any questions for our speakers, you can go ahead and put them in the chat and I can ask on your behalf. As you were giving your talk and just laying out the demographics, I'm curious if there's any differentiation in generation, like newly immigrated, first, second, third generation, and does that show up in the data?
So for mental health, are you talking about like just rates of mental health issues?
Yes. Yeah, and the approach, and if there's differences or nuances with between generations and how one might view or frame mental health compared to the previous generation.
Mm-hmm. Yeah, I mean, I could probably start us off, and then Dr. Beck, if you have anything else to add.
Yeah.
I would say clinically this comes up quite a bit. I mean, we oftentimes the parents that we're seeing are parents with their kids or teenagers who are coming into clinic. It's parents who, immigrated, maybe have been in the U.S. for 10 plus years, for example, but their child or their teen was born in the U.S. And so oftentimes there is a little bit of that stress or difficulties kind of communicating or discussing issues of mental health. I think parents come in maybe with an idea of, we don't know what anxiety is or what depression is or what it looks like. Whereas the teen or child, for example, who's maybe grown up here, gotten exposed to a different system than parents have maybe a sense of, from being in school of how mental health has been talked about or shared about. So I feel like oftentimes it does end up being clinically useful for us because it provides us information for how to talk about it and explain to the parent about those issues. And I think it does impact treatment quite a bit as far as when we're delivering anxiety or depression treatment. For those reasons, we do have kind of components that are broken up a little bit, where we do work with the parents specifically in a group setting where we talk about strategies, we talk about depression or whatever topic mental health topic that we're discussing. And then with teenagers, we have a separate group. And I feel like the psychoed piece around mental health becomes really important when we're working with parents, because that there is that, that mental health was not often talked about in their upbringing or their home country. And so I think psychoeducation around that becomes really important when we're working specifically with families who maybe recently immigrated or aren't immigrants to the U.S. Dr. Black, what would you add?
Yeah, all of that totally rings true. Like, I would say, like, one thing that kind of has come up when we've been looking at the literature on this as well has been like those kids who were kind of in that in between space of like, maybe their parents have immigrated from another country and they have primarily grown up like here. Has been just like what is the kind of impact on their mental health, like of being in that like third culture kid like position. And one of the things that has come up has been like the protective factors of like having some of those like positive like cultural identity and like connection to like their family's identity, that can be like a major protective factor mental health wise. And then also at the same time being in that position can come with its own stressors. And so one of the biggest ones that comes up is language brokering, like kids that are heavily relied on to be kind of the language broker or interpreter for their family in different situations. That can be associated with more like stress and mental health impact. And like similarly, if they're the ones navigating sort of like connections with the school and like, getting the IEP figured out and like maybe the school is not providing enough like support around like interpreter access and things like that, that can lead to its own mental health impacts for kids, as well as differences in like, Dr. Trevino is saying about like, what the parents like concept of their symptoms are versus what the kids' concept are. So.
Thank you for that. Let's see. Any other questions? I think what was surprising is like there wasn't a whole lot of studies done related to COVID impacts. I think that's really surprising because I think there was so much, I think, focus and highlights on how it had impacted the Latinx community. There's a question: what is needed to grow the program?
Yeah, and that's from Chris Fernandez, who we know very well. And grow our program as far as our comma clinic. I think that is a big question. I think we're slowly growing, which allows us to continue to see more families. So we went from just myself and Dr. Black, and then now we have another psychiatrist and a mental health therapist who are really, helping us continue to provide access.
Yeah. And then I think also like one thing that has been helpful for the growth we have had has been like whenever you're working within a large institution like Children's, and we both are faculty for UW, and so like we're part of like a much bigger thing that has a lot of like standardized systems, standardized processes for how everything is done. And like one thing that we have really tried to advocate for is like sometimes the default process or like the way that things are done everywhere else is like not necessarily going to lead to like equitable care for our patient population. And sometimes, as we know, like discrimination and like unequitable like processes are sort of built into the system, even if that's not like the intention, that can be the impact. And so having like flexibility and having like, us being allowed like the ability to maybe do things differently than other programs at Children's, and to sort of like innovate and adapt and then like evaluate, see how that goes. And if it goes well, to be allowed to like do things a little differently than the standard process, I think has been another thing that's been super helpful in growth for CALMA.
Thank you. And I know that your program is, based in Seattle, but are there plans to, branch out into Western Washington, where there is a higher percentage of Latinx populations in those areas?
Yeah, so our physical location is actually here in Seattle, like you mentioned, but our services are still over telehealth, and we have seen a proportion of families in Eastern Washington, although it's not to the same degree, I would say, as families on the western side of the state. So I think part of that has to do with we have to have a better way of connecting with communities in Eastern Washington, because when we were doing our needs assessment, actually we mostly talked with mental health agencies here on the western side of the state, and I think we didn't actually assess or connect with communities, mental health agencies or sites in Eastern Washington. So I feel like the establishment of COM is still really early. Like we've only been around for about 2 years, 2 maybe going on 3 years, and so I don't think we have yet the established kind of reputable presence in the community in Eastern Washington. But our goal is definitely to provide extended reach into that area, because as you said, there are just a higher proportion of Hispanic and Latinx populations in that region.
All right. Well, thank you. I'm excited to hear about your program as it grows, and the outreach that you're doing to the community. Thank you so much.
Yeah, thank you. Thanks, everyone.
Thanks for having us.
Thank you. Bye. Have a good rest of your afternoon.
Bye. You too.
Bye.